You're listening to Healthcare Now Radio. Stand by for This Just In, the latest in healthcare innovation and technology trends with your HIT advisor, Justin Barnes.
Thank you for tuning in and welcome to This Just In. I'm your host, Justin Barnes. In this half hour segments, I'll bring you the latest advancements in healthcare, strategy, innovation, and public policy. As always, we're broadcasting from the This Just In studios on the Business Radio X network, as well as the Healthcare Now radio network. And before we dive in with my special guest today, I want to take a moment to let everyone know that we will be broadcasting the This Just In radio show again live from the HIMSS annual conference next March in Las Vegas. Many more details to come, but I hope everyone is planning on attending. We'll have another great slate of CEO, CIO, leading care providers, industry thought leaders, and certainly policymakers joining the show. But for this episode, my 111th episode, we're going to speak with a good friend and thought leader, Tom Foley, Director of Worldwide Health Solutions Strategy for Lenovo Health and co-founder of the Health Innovation Think Tank. Welcome back to the show, Tom.
Thank you. Good to be back.
It's great to have you back. And we scheduled today's show to really cover our most recent think tank that we hosted at UPMC in partnership with the Center for Connected Medicine. And this is our third show on the topic. But a lot of my audience knows where it came from and how we originated it. But for those that are new to the show or new hearing about the think tank, talk about the genesis of where the think tank came from.
The think tank actually originated at last HIMSS. It was on your radio show when we were talking about innovation and the inhibitors to innovation, and there needing to be a voice relative to what is actually working and what's not working. So actually, it was shortly after HIMSS when you and I actually got together and started thinking about how can we best serve that gap that we constructed the framework and held now two separate sessions.
Yeah, they were. It was a great idea that you brought forth, and it was just a great opportunity. There's a gap in the industry, and you saw that, and you articulated it in such a way that a lot of these associations, and I also saw this myself, is a lot of associations they have one type of participant. They might be, I'm very familiar with EHR vendors or interoperability players or health IT vendors from a specific sector of the market. Maybe patient portal companies. They all start their own types of industry associations, and we were thinking much bigger. Like, how can we bring all of these collaborators together, all key stakeholders? So why don't you roll through some of your initial ideas on the different players and key stakeholder groups that are very important to the think tank?
Well, to us, it was not just about having health systems in the room. It was really about bringing together the different stakeholders to have a collaboration. And so therefore, health systems, leading innovators on the technology front, payers, policymakers, and having them collaborate on very specific elements associated with virtual care, connected health, and value-based care. It was something that we thought was needed, and even in the collaboration, it wasn't around a panel discussion where some folks are up on stage and talking and not having the ability to engage fluently throughout the dialogue. This was 50 people in a room and moderating a conversation with all 50 at the same time to glean out what is working, what's not working, what's the path forward relative to moving the needle in the delivery of care model.
Yeah, that's really where I think the think tank is very different than anything that I've ever been a part of or I've ever seen, even where you mentioned we bring together 50 thought leaders, and they're all key stakeholders in their own right. And so to have a collaborative discussion among 50 thought leaders and just leaders in general in the industry, and then gleaning out their best practices, their experiences, what they know to be successful and what they know not to be successful, so we can again learn from each other and begin to crawl, walk, run, and run together as an industry and move this industry forward.
Yeah, and the big thing that I've learned throughout this process is that the larger health systems, they have at least a little bit more flexibility in their spend in investigating some innovative ways to change the delivery of care, where a small hospital doesn't necessarily have that flexibility and struggle a bit more on how and how to proceed forward. And so when we talk about bringing hospital executives in to participate, it's kind of a mix of large and small, so that we can get perspective, and everybody learns across the board. I think it's been pretty powerful.
Yeah, that's also, I agree. And what's been exciting to be a part of this for me is just to see, we had some small rural hospitals, some critical access hospitals, as well as the largest health systems, the top largest health systems in the country, and most progressive as well. So it's kind of cool to have the entire spectrum, actively participating in our think tank each time even.
Yeah. Exactly.
So what, we're going to cover some of the best practices and key takeaways, something that's just basically whet everybody's appetite. We're going to publish those here very soon as well at a grand scale. But, what do you hope to achieve through the think tank over the next year? What's the goal?
Education. It's a learning experience, bringing people together to collaborate on a path forward, and so that it's not just about one hospital doing something, it's about all hospitals doing something, or the ambulatory care facilities. It's about how do we all learn and move in the same direction, because the market is really just totally disjointed, and but there's a lot of great ideas, and what works and what doesn't work. So let's mitigate the expense on things that don't work, and so that we could demonstrate and move forward quickly on things that do work. And what works in California may not work in Massachusetts, but at least you have a framework of something that does work, and you can spin it towards your respective geography and community in order to maximize success.
Yeah, you bring up a very good point, and something actually we've been finding even over the last couple of weeks as we're pulling together and parsing all of the different key takeaways and best practices that we garnered in that last think tank is we have a lot collected, and I think we're going to publish really all of them because they're relevant to different people. It's one of the really things that we found is exactly what you just said, is some are going to be relevant to somebody in California, some are going to be relevant to a small health system, some are going to be relevant to a medium size, some are going to be relevant to a innovative health IT vendor or a payer, and so they're all over the board. And that's one thing that's really neat is we're not finding one type. We're actually educating, and then we're basically telling everybody some key strategies to be successful, and then also how to understand other players in the market, because we're very myopic in some ways, but now we're kind of see the playbook for everybody. And everybody understands how everybody else can be successful. We can understand their perspective better. It's a great communication tool, I've noticed.
Yeah, and quite frankly, I mentioned California and Massachusetts specifically versus how even other states, because Massachusetts, relative to their state policies and regulations on the delivery of care, is different than California, and California is different in and of itself. But they all have strengths. Taking politics totally out of it,
right?
They all have their strengths, and we should be able to learn from the advancements that others have taken, and not only looking at what is taking place here in the U.S. But Lenovo has a specific advantage of looking globally and seeing what's working there, because we're all challenged with the same problem: growing population, aging population, sicker population, less doctors and nurses available to take care of that growing older sicker population. So different care models, different geographies, but we have a different vantage point than most in this market.
Yeah, and to be fair, even you're spot on. We have North Dakota represented as well, so we do have every part of the country. That's right. And there's some of the most active players come from the dead center of the country. It's really, really cool, active participants. So let's dive in a little bit, whet the appetite of our listeners around some of our key takeaways, because this last one was extremely exciting to be a part of, and some really cool stuff emerged around best practices and key takeaways. So why don't you bring up, and I'll sprinkle in some as well, but why don't you bring up some thoughts around value-based care? Again, we'll publish all this here very soon, but your thoughts on value-based care, what you got out of it, and some of the big aha moments.
Value-based care, I think UPMC led it best. And really, before you do anything, you really need to understand the community. Mm-hmm. And they've spent some significant time taking the data and understanding geographically where does care most needed. So looking at a topology of their geography and knowing that in this community there's a high degree of diabetes, and another community it's a high degree of another condition, and then moving care closer to those communities and giving the specific focus was important. And UPMC, being a payer and a provider, lends itself to being a little bit more nimble relative to how do they engage the community without, certainly financials are always a key construct, but just being a little bit more innovative in what a payer pays for in order to advance the quality of care and ultimately attempt to reduce its overall cost as they engage their community.
Yeah, you hit it on the head. That was the big one for value-based care. Yeah, it was really neat where they used, I guess they call it the area deprivation index, and they can actually tell where there's episodes of cancer or CHF, congestive heart failure, or diabetes, and like you said, they deploy care teams, and I think those are great strike strategies. However, the overarching approach is also what we're starting to see nationwide, where payers and other groups are going more at risk, and UPMC has gone way out in front of that one by really becoming a very strong payer for Western Pennsylvania and even Central Pennsylvania. But they're doing it at a much larger scale. But there's a lot of health systems. This is a trend, but now they've shown a little bit of the playbook on, all right, you're now a payer. Well, what else you got to do beyond just, reducing reimbursements or better managing reimbursements, which is also very important to manage those reimbursement structures. Yeah. But how do you go lower costs specifically without just making cuts, draconian cuts? They go out there, like you said, they deploy care teams and they proactively engage their community and not waiting for them to walk through the emergency room.
Yeah, they actually gave advanced definition of what we always hear is that it's always about the data, right? Yes, that's right. And in this context, I'll split hairs and say it's about studying the data and across the topography of that community. As certainly clinical data about a particular person and making sure that health record is 100% accurate is important, but they took it to another level relative to looking across their community and being able to dissect where is care most needed and implementing a delivery care model that best serves their community, and at the same time have quality data at the point of care for each individual patient as they come into their care facilities.
Very true.
It was very eye-opening relative to what can be done. And here's an example of, it takes a lot of time, money, and resources to mine the data that they've mined across a payer and a provider institute. Yeah. And this is where the smaller hospitals may be at a disadvantage because they just don't have the resources to do that type of effort. And here's where we can start to create programs where potentially there's some sharing going on about how to do it, again, to mitigate some costs for those smaller hospitals.
Yeah, a good point. So moving along, let's kind of cover a connected health. So what's your thoughts on one or two best practices there, or key takeaways in that discussion?
Well, connected health was really about the bedless hospital. It's interesting how the market measures themselves today about how utilized their beds are, and the model of tomorrow is how the model of success is that their beds aren't utilized. If they're really going to reduce the cost of care, they really need to change the delivery of care workflow. And ultimately, I think we came to the conclusion that the home is becoming that center of care or a setting of care. And if that is ultimately true, then how does one engage a consumer, a patient, while in their home versus forcing them to come into the most expensive facility in the delivery of care apparatus, and that's the hospital.
Yeah. No, it's true. And Razu, Dr. Shresha went through a great plan. And again, he's with UPMC, and they're very unique because they have taken on the payer role as well. But again, that is a growing trend. They're not unique. It may be unique in some settings, but they're really not. You're going to see that trend picking up across the country over the next 3 to 5 years. I'm certainly watching it in a lot of the pockets that I work and focus. But and they get a great articulation, really evolving from a fee for service to an outcomes driven collaborative care model, and just seeing that, and not only seeing it in strategy, but they're also deploying it, and it's very, very cool, and to show that collaboration is key.
Yeah. I did a panel, moderated a panel at U.S. News and World Report last week, and Nemours Children's Hospital was on the panel. Gina, she did what they're doing relative to connected care is very innovative as well, and ultimately it's about how do I reach my patients in their home and engage them accordingly to mitigate, to maximize their engagement, mitigate their cost, and certainly move the needle relative to the quality of care. Some very interesting models across the continuum here about how to do this differently.
Yeah, which actually leads us to our third topic, just closing out the think tank discussion, is to virtual care, which is exactly where you were going right there. But where and connected health kind of integrated. So what's the one or two best practices out of the think tank that you liked for virtual care?
Well, what Boston is doing relative to the RED project, and they've done some clinical studies that talk about how they engage the patient prior to discharge using a voice animation avatar type of engagement to educate the patient on what is needed upon discharge and what their expectations should be over the next 30 days. And they have seen some significant reduction in the readmittance based on their particular program. It's a classic case of how technology can be a tool to engage the consumers and patients to maximize the delivery of care and mitigate their costs. They've done a phenomenal job.
Yeah, they have. No, and we've seen that in the last couple of think tanks where they also continue to evolve, which is very neat. So this is a growing strategy. This is going to get very strong, and even leading into that is the whole, where the virtual assistant enabled care is coming from, and we see Amazon jumping into that with Alexa and their health skills. Google's going to get involved and others, but I'm most excited about what Amazon and Alexa is doing, just from what I've been able to see as part of our think tanks. And I think the company is Orbita. Is that the company that has a health skills?
Yeah. So for clarity, Amazon provides Alexa, but Alexa, as it's released from Amazon, has no health skills. It's really, when we talk about bringing innovators into the think tank, Orbita has really been kind of the leading player in the market relative to create, because folks would say, Alexa, HIPAA compliant?
Right.
I don't think so.
Right.
But they've created a HIPAA compliant Alexa platform. They've created some very significant health skills. So how does Alexa, with a nursing degree, as I say, provide guidance to that patient while in the home? So, because ultimately, we can get into virtual care and, the Internet of Things and data collection and things of that nature, but hospitals often don't have the resources to monitor all that data. So Alexa could be a very good substitute for a health coach. And we say that based on what we know from the Boston Medical Center RED project.
Yep.
Reducing readmittance by 25% is a significant cost savings to a hospital.
Yep.
Billions.
Yeah. No, and the other piece that I saw is, and I would be remiss, we just recently had CMS publish their CPT codes for reimbursement on telehealth just recently this week. So, and over the last couple of weeks. So we've seen some great advances on the virtual care side and the telehealth side, and we're going to continue to see that, which leads me into the device that I loved. That the moment I saw it through you, and then we saw it used during our think tank, is the ARC device. So tell us about that in a couple seconds here.
Yeah, at the end of the day, I think of my 82-year-old mother and having cancer at home and being cared for by my sister and certainly others helped. But good thing she had 6 kids. But the point is that the Internet of Things isn't a model that works in the delivery of care, in my view. So how does my 82-year-old mother be mobile and be able to take blood pressure, heart rate, respiratory, SpO2, temperature, potentially, if it was my father, measuring his diabetes and an ECG machine, single phase. You might think, geez, all those different devices, there's no way, they're going to be able to manage all those different apps and all those different and afford all those different devices. What we've done is we've consolidated every one of them into one device, a very modular device that is held in one hand, press a button, and all the vitals are taken. It's the first, hopefully, when we get, we are seeking FDA approval. So this is clinical data, not consumer data. And we're seeking FDA approval on 5 of those vitals, hopefully by February, and the other 2 by Q3 of next year. It'll be the first blood pressure device that is FDA approved, taking blood pressure from the finger. And hopefully, if we're lucky enough to get FDA approval, it'll be the first FDA device that allows us to measure our glucose level without pricking your finger. And the payer themselves spends $1,000 to $4,000 a year just on sticks.
Yeah.
If we can reduce that cost and create mobility and ease of use, number one reason why folks with diabetes aren't able to manage their diabetes well, because they hate pricking their finger all the time. Right. Yeah. Take that off the table, reduce the cost of that, and it'll maximize awareness, which leads to education and action. So. Yeah. Our view is that the Internet of Things is a thing that does that has multiple features that helps mitigate, maximize the ability to collect vitals, and also the same device being a telehealth platform that might actually have Alexa stuck in the middle, if you will, with some health skills. So I can collect vitals. I can become a health coach through Alexa, and if my health system wants to talk to me, they can have a virtual encounter all through a very simple device.
Yep, and it's the size of an iPhone. But also we have only about a minute and a half left or so, and I do.
For accuracy, there it's the size of the Moto Z2 smartphone.
That's awesome. That's awesome.
Versus the iPhone.
Yep.
We do it better.
As I certainly do. But we have about a minute here left, a little bit over that. But I know you've hosted a couple other panels, and you've come across some great strategies. I know we're running low on time, but can you hit maybe one of those that you saw, or always dangle it, and we can have you back in a couple of weeks or so to flush it out more?
Well, I mentioned Nemours relative to implementing telehealth across the continuum of care, and they have some very specific apps even in the asthma space to help children with asthma. I thought that was a very, very compelling effort.
Yep.
And interesting enough, Montefiore Hospital, interesting story. I'll try to make it short and sweet. They, everybody says keep people out of the hospital, keep people out of the emergency room. It's the most expensive. Don't do it. They actually flipped the model and said, you know what? We're going to create the first freestanding emergency room in the state of New York, and enhance the delivery of care through that facility. And the results that they got out of it was really astounding. They have increased the quality of care in that community, and created a facility that people would go to, not only for the emergency that they have, but they extend their resources and they're connected to a larger health system, so they can direct the consumer or the patient to other services as they come in for care. So it's not necessarily just about emergency room, emergency department. It's how does it fit into the overall ecosystem, and then how do you create continuity between an emergency department and other facilities within your health system. They really have done a really unique job, and to make it cost effective.
Yep.
It just tells the market that they might be looking at their emergency room a bit different than they had.
No, that's terrific. And I'm going to obviously have to have you back too, because I know there's some other pieces that we've talked about offline that I certainly want to bring out. You're just coming across some really great best practices in a lot of your work. So we'll have you back. But Tom Foley, Lenovo Health, always great to have you on the show, my friend. And I appreciate you taking the time out of your busy schedule to join us.
Awesome. Good to be here. Thank you.
Thank you. Thank you. And thank you to everyone for joining us today. Please tune in weekdays, 2:30 p.m. Eastern, 11:30 a.m. Pacific. As always, you can track me on Twitter at HIT Advisor and use the hashtag ThisJustinRadio so we can respond to your comments from the show. In addition, all my content's always posted at justinbarnes.com. Thanks, everyone. Have a terrific week.